Today's skill demo is going to be on conducting a respiratory assessment. So we are not in a clinical setting right now, so you'll hear me kind of explain some of the things that we don't have access to here that you would have access to in a clinical setting. So to begin the exam, just noting as part of the lesson plan that the student would have the ability to have about 10 minutes to discuss with their instructor any questions that they might have prior to proceeding with the respiratory exam. They're going to go into the exam room, conduct a respiratory exam. They're given 2 cues if they need it throughout the portion of the exam, and then we'll go through a debrief after in order to answer any questions and provide some feedback. So first and foremost, when you're conducting the exam, when you walk into the room, which I would do here, is perform hand hygiene, walk into the patient's room, and then apply gloves. We don't have gloves here, so we're gonna pretend that I foamed in, came into the room, and then I applied gloves. So the first part of the exam is just going to be assessing kind of your patient in terms of where they are, do they know what's going on? And so I'd introduce myself and say, I'm Jared, I'm gonna be your nurse today. And then I would ask, what is your name and date of birth?
Anthony Merritt, 5/14/97.
All right, and then do you have any allergies that you know of?
Nope.
And do you take any medications, whether prescribed or over the counter?
Nope.
Perfect. And so we're going to be doing a respiratory exam today, so just letting the patient know that. And then also asking, like, are they aware of kind of what a respiratory exam is going to look like, and have they had one done before?
Yes.
Perfect. So pretty basic questionnaire stuff. One of the things that I like to point out is that right from the doorway, when you're walking into your patient's room, you're already inspecting your patient. So I'm looking at how he is sitting, and he's not hunched over, he's not tripoding, he's not pursed lipped breathing. He looks very comfortable. He looks like he's breathing nice, even, and unlabored. So those are things that I like to note. As we go into the exam and I'm inspecting the patient, typically in a clinical setting, you'd be removing the patient's shirt. But for here in privacy, we're going to keep and allow him to keep his shirt on. So I'll kind of be talking through the assessment, and then you just picture it that you'd be taking your patient's shirt off, or at least lifting it in order to expose the skin to see any work of breathing. So we kind of went through some of the inspection pieces already, looking at any signs of circumoral cyanosis or any work to breathing, and he is not having any of that. One of the things that we want to look at too is where he is in position when we're conducting the exam. So definitely wanting to put a patient in a comfortable position. For some, that's, if they're lying in bed, maybe raising the head of the bed or having them sit up. So the first part of that exam is the inspection, which we did, kind of walking through the door, and then again assessing the patient as we approached. You'd be looking at skin, again, under his shirt for any types of retractions or nasal flaring in babies or tracheal tugging, any of those things. The next step would be palpate. So I'm going to actually have you turn your legs kind of over and face the window. And one of the things that you want to first do, and again, you would have had gloved hands, but you just want to inspect the trachea and palpate the trachea, making sure that it's midline, making sure that there's no bulging, and making sure that there's no lumps, bumps, or anything of that nature, which I don't feel in this patient. You're also going to want to assess the symmetrical chest rise and expansion, which we kind of have seen with him normally breathing, but you can also take your hands and then place it on your patient's back and ask them to take a nice deep breath in and out, and then in and out. So he's having nice symmetrical chest rise. One side is not inflating more than the other. And did you have any pain when you were doing any of that?
No.
Perfect. So the other thing that we want to assess is for phlebitis. So it's the technique of asking your patient to say 99. I'm going to place my hands on your back. I'm going to ask you to say 99, and you're just looking for equal vibrations in both sides of the lungs. So I'm going to say 99.
99.
And again.
99.
And one more time.
99.
Perfect. So nice, equal, and symmetric. So you can turn back into the chair. So the next part of the assessment is to percuss the patient. And it's one thing that in the clinical setting, I think a lot of times we skip over and we just do right to auscultation. But for the purpose of your lab checkoff, we just want to make sure that we are percussing all of the lung fields, both in the anterior chest as well as the posterior. And we follow a nice repetitive pattern. So that pattern can switch, but basically you want to start on one side, go to the other, move down, and go to the other. And you're really looking just for symmetry. So all the things that we're doing in terms of our assessment are looking how the left lung compares to the right lung or vice versa. So just explaining to your patient that you're going to be putting your hand on their chest, you're going to be kind of doing a little tap on your hand. They might feel a little bit of pressure, but it's not going to be painful at all. All right, so then you start on whatever side you want, and then percuss here. And you want to make sure that you get the outer lung fields as well. And normal findings for this would be resonant sounds all throughout your lung fields, and then dull sounds over any organs, so spleen, liver, etc. So I'll have you again swing your legs over to the window, and you're going to follow the same thing again. The areas and how you percuss is exactly how you're going to auscultate in the next step, so it's kind of a nice comparison. So you're going to do the same thing on the patient's back lung fields. And again, don't forget your outer lung fields as well. And the patient is having, again, resonant sounds all throughout those air-filled spaces, and dull sounds noted over the organs. So the patient can again turn back into the regular position, sitting in the chair, and then you're going to auscultate. So you're going to listen to the patient's lungs, again comparing right to left. So this is where we've already kind of asked the patient, do they have a history? Do they have any shortness of breath? Are they having any pain right now, which he's denied? But definitely looking at what type of patient you have, whether they have a history of asthma, whether they have a history of, if they're a younger child, reactive airway, and some of the things that you might hear within a patient's lung field. So crackles, wheezes, rhonchi, even pleural friction, rubs, stridor, any of those lung sounds that you want to be familiar with, because not every patient is going to have clear lung sounds, but definitely wanting to be aware of what's normal and what's abnormal in case you're in that clinical setting and have to make that judgment. So one of the things that I like to do is warm the stethoscope, really just because it's nice to the patient. So I like to kind of at least put it in my hand, rub it a few times between my hand before I'm going to put it on the patient's skin. We like to do assessments. Being a night nurse, we do assessments overnight. And so there's nothing that's going to wake a patient up faster than a cold stethoscope on their bare skin at 2 a.m. So we like to kind of be nice to our patients. So getting in that practice, whether it's in simulation or whether it's in the clinical lab, is really important. At this point, because we're not concerned with the patient having any work of breathing or difficulty, shortness of breath, I would have the patient breathe normally in a comfortable position for him. If he was having shortness of breath, I would really want to have him take nice deep breaths as I'm examining all of his lung fields, but he's not having any shortness of breath that he reported. So I'd have him breathe normally so I can hear all of his lung fields. I'm looking for what are his lung sounds, how is the aeration, so is the air moving all through the lung fields, and then comparing it right to left again. So you're going to follow the same technique that you used for the percussion in the same order, and then you're just going to be using your stethoscope to auscultate that. So I'm going to start. Good. And then I'll have you turn again, and you're going to assess the posterior side of the patient as well. So this patient has clear lung sounds all throughout. You can rest into a normal position. He has clear lung sounds all throughout, great aeration into the bases of both lungs. So when you're auscultating and how you report it is vesicular breath sounds. You should be hearing vesicular breath sounds throughout. Some bronchovesicular breath sounds are usually noted into the bronchioles, into the main bronchial area, and then your bronchial breath sounds would be more up into your trachea. But all those air spaces should be nice vesicular lung sounds, and that those lungs are clear. There's not any crackles, wheezing, coarseness, and he is not dim in his bases. I like to point out too that part of your assessment, once we walked into the room and we were inspecting the patient, which is the first part of a respiratory assessment, you're making note of their respiratory rate as well as their respiratory depth, but the same goes for when you're auscultating the patient as well. Looking to see that rate is still matching as you're hearing those breath sounds versus just inspecting the patient as well. So at this point, you would instruct your patient that the exam is over, ask them if they have any questions, which he said he does not, and then reporting any findings. So with him, it was a normal respiratory assessment. For some patients, especially if family is there or parents, right, you might want to make note, especially based on their diagnosis, maybe they still have crackles, maybe they still have diminished lung sounds, and then record those findings as appropriate. When you're recording in the clinical setting, a lot of the assessments that we do give you the option to record within normal limits. And what that means is that it's assuming that you've assessed all parts of that assessment, from inspection, palpation, percussion, auscultation, and that every single part of that assessment is normal. So that's what within normal limits would mean. If there's any part within that assessment that is abnormal, it would warrant you to not put within normal limits and clearly document exactly how that respiratory assessment turned out. So definitely within your clinical setting, wanting to get used to the charting and how those areas are charted. So at this point, the exam would be complete. I would remove my gloves, put them in the trash can, perform hand hygiene, and then assist the patient out of the exam room.